used to. So then over time, for some reason, they put some pit on. I guess they thought they needed to expedite this delivery. She gets some ampicillin. They did turn down her pit to 4, but she still has some tachysystole there. They turned down her pit to 2, and it's hard to see on that strip, but the baseline, the baby's baseline is rising, so it's close to 160 now. And then over time, and this is again like talking about the evolution of your strip, you see that the baby's losing variability and starts to have some decels. There's still quite a bit of uterine activity there, and they're doing their interventions, they're doing their O2 and things like that. And she goes to OR, and then 14 minutes to her C-section, and has a baby with a pH that's not really what you want to see. Good example of a standalone category 3 bad strip, a sinusoidal fetal heart rate pattern. Sinusoidal, by definition, is a visually apparent smooth sine wave-like undulating pattern. And you have 3 to 5 cycles every minute. So if you go from a minute to a minute and you count how many cycles are there, there's like 4 there, and there was one over here that had like 3 in there, and one of them that was closer to 5. And so you have 3 to 5 of those cycles every minute, and it persists for greater than or equal to 20 minutes. Because you do see babies that go into a sleep pattern that looks a lot like this. And some medications will cause what we used to call a pseudo-sinusoidal, where it looks like this, but it's a drug-induced sinusoidal. If it's a true sinusoidal heart rate, then it's not a good thing. It's an ominous sign, because it usually means you have severe fetal anemia. Somehow there was some sort of cord accident, bleeding, abruption, ruptured vasa previa, or maybe a mom that didn't get the best prenatal care, that didn't get her RhoGAM. So she'll have a RH-ISO immunization where her cells are attacking the baby's fetal blood. Also, if you have a severe hypoxic or acidotic episode where there was an insult and perhaps a baby had a stroke. Brenda Cherry had a patient she took care of that she put her on the monitor, and that strip looked just like that. And that baby had a stroke in utero. I talked about this a little bit earlier, a couple of slides before. There are physiologic states and drugs that cause those sinusoidal patterns. What's funny is if a baby's sleeping, or if they're sucking on their fingers or something like that, that does cause that up and down sinusoidal pattern, and narcotics will cause it temporarily. So if you have had a patient who's had a good strip initially and during the labor, and you get some sinusoidal, you can watch it for a while. You know, it needs to continue for greater than 20 minutes, and if you're concerned, you could just do a scalp stim or something like that, and generally then if that resolves it, or the baby has a positive reaction with an XL, then you can be sure that your pH is at least 7.19. All right, documentation and assessment for your patient. You're going to do your assessment and evaluate, and then you're going to document. So if you have a patient that has no risk factors, which is almost none of our patients, in the first stage of labor, the active phase, you can document every 30 minutes. In the second stage of labor, when they're actively pushing, you document every 15 minutes. And a patient that is at risk, which is almost every single one of our patients, because all they need to be is on PIT, and they are considered having a risk factor. So they need to have documentation in the first stage of labor every 15 minutes. Second stage of labor is every 5 minutes. Okay, here is a example question. Using the NICHD nomenclature, which of the following terms refers to decelerations occurring with less than 50% of contractions? It's either intermittent, recurrent, or repetitive. And we know it's not 3 right off the bat, because repetitive is a terminology they don't use anymore. Recurrent has to be greater than 50%, so your answer is intermittent. So let's walk through this tracing. If you pull out your little round chart with those 3 circles and go through this strip step by step, I don't think that will fail you. I think that you'll be able to come up with the right answer each time. So if you look at what normal, we'll start with the top. Is it normal? Well, if you look at all of what is required, moderate variability, I would say sure, there's probably some moderate variability. If you have a couple of 2-minute pieces you can put together there, you probably could say that you have moderate variability. And your baseline needs to be within 110 to 160. And you could probably piece together a couple 2-minute segment there to say that it's close to 150 or thereabouts. They're not going to ask you on the test what is the baseline. They're going to ask you what your category of strips are. So that was what your interpretations are going to be. So it needs to not have any late or variable decels. So right there, that makes it not qualify as normal. So we're saying that perhaps it's indeterminate. So then you go to your other circle where you're looking for your abnormal. For abnormal category 3, you have to have absent variability, which we're saying you don't have that, with recurrent late decelerations or recurrent variable decelerations. So for this strip, we would call this a category 2, because you still have some reassuring, which we don't use anymore, I shouldn't say. You have some things that qualify it as normal, meaning normal baseline and moderate variability, but you do have variables and such. So that makes it category 2 indeterminate. Another example question, and I remember that this one was absolutely on the exam. If an acceleration of the fetal heart rate is elicited during fetal scalp stimulation, the fetal pH can be assumed to be at least what? And I said it at least 2 times that I know of. It will be A, 7.19. Again, commit this to memory. This will be your friend. This will help you interpret all of the strips that you're going to see on the exam. This just kind of is a little flow sheet that goes through your steps. And again, it looks at what's going on and what you do for each thing. So obviously, category 1, there's nothing going on, so you've got routine management. Category 2, this one, if you have some moderate variability, intermittent decels, and you have presence of accelerations, you can continue surveillance and do your intrauterine resuscitative measures. So you're going to do some repositioning. You can either leave your pit on, and this comes from our policy. You can either leave your pit on or you can cut it in half. You don't have to turn it off. So fluid bolus, and there's some debate about if you have pit on, can you have oxygen on? I mean, it's not really encouraged, because if you're concerned enough to put oxygen on, you should probably turn your pit off. So for moderate variability, intermittent decels, and some accelerations, you can maybe alter your pit a little bit, do your other interventions, and you can continue to watch. You don't have to turn off your pit according to our policy. You could half it. If you have recurrent decels, minimal variability, you do all your intrauterine resuscitative measures, and if it doesn't improve, and there's nothing really that says in the policy or in the literature how long you have to wait to see, or how long you can allow this to continue, but you need to see some changes, or, you know, again, we talked about the evolution of the strip and what's happening. So if it's not improved and it progresses to category 3, you have to consider delivery. But I think if you've got that next step worse of your category 2, where you're getting some minimal variability and recurrent decels, I think, you know, your PITS needs to be off. And then if you're turning your PIT off and you're not seeing a little bit of change, you're putting some oxygen on, and then by then you're hopefully heading back the other way. If not, and you're at category 3, you got to consider delivery. So if it's category 3, you're already thinking about, what do I need to get ready in case we have to go to C-section. You're doing all your intrauterine resuscitative measures, and if it's not improved in a short amount of time, you're going to expedite delivery. And again, there isn't anything that says how long you wait for that, but if you're progressing to a category 3, you need to really be keeping in the back of your mind, how much longer can this kid go on, because that's always the biggest question, that I should say unanswered question. How much longer can this kid handle this? How much reserve does a baby have? Again, to review all your intrauterine resuscitative measures, you change maternal position, decrease uterine activity, IV fluid bolus, correct maternal hypotension, put on your oxygen. You can attempt an amnio infusion. That's always good for a cord involvement if you have some variables. You can alter your pushing efforts, meaning push every other or every third, and elevate the presenting part if there is a cord prolapse. All right. Not too much to say about that. All right. So here is a baby that's on the monitor, and the water breaks, clear fluid, and then what do you think is going on there? I think the first thing you're going to do is you're going to rush in and check her, because that's the answer to every question, is check your patient and see obviously if what's going on. And I'm sure you're all saying in your mind, is there a cord prolapse? Also, it could be a fast descent, right? You know, her water broke and then all of a sudden the baby is almost crowning. So what are your interventions here? I mean, hopefully that if, you know, your delivery is imminent, if you check your patient, you're feeling for the cord. If it is, you're going to elevate the presenting part. But you're definitely getting some help in there. You know, you're doing your code assist, your OB code assist, to get some help in there, because you're going to need help repositioning. You're going to need help getting your fluid bolus, things like that, putting on any oxygen, getting your provider in there. So you're doing all of this, and hopefully it's because delivery is imminent. And if it's not, as you can see towards the end here, I don't know if this is because the baby's coming out or it's still staying down there, you're going to be moving towards an operative delivery. All right. Always think about promoting fetal oxygenation and improved uteroplacental blood flow. You initiate lateral position, left or right. You can even do knee chest on all fours, whatever works. Give an IV bolus. You could discontinue or half your Pitocin, or remove your cervical ripening agent. Administer O2. You would consider a tocolytic. That is, you could suggest it to the provider. It would be their call. I wouldn't rush to get it and give it if you think you need to. But they should consider it, and you certainly could make a suggestion if it's severe, if you have a real tetanic contraction and your baby is really having a rough time. If you're in second stage, you should consider pushing every other or every third contraction. Now take a breath again and look at this beautiful beach vista. Think about how we all want to be there. You want to retire there, right? And it would be a good place to take a break if you want to.